Hello, everybody. Welcome to the very first international panel discussion about the surgical treatment of arthrofibrosis. I'm very honoured to be moderating this. I'm Kayley Usher from the International Arthrofibrosis Association and the University of Western Australia. And I'd like to introduce Dr. Kristoffer Barfod from Denmark, Dr. Ralf Rosenberger from Austria, and Dr. Jason Dragoo from the USA. Unfortunately, Dr. Diabate may not be able to join us this time. I really appreciate all of you joining us, and I encourage you to share your thoughts and experiences on every topic. And I may also share some of the patient experiences that I've heard as the founder of the International Arthrofibrosis Association. And first, I'll give a little bit of background about arthrofibrosis. It's unfortunately a common complication of joint injury and surgery. It's characterized by stiffness, reduced range of motion, and pain in active arthrofibrosis, although it's hypothesized there's also a residual form in which pain is not a real issue. And it's caused by excessive scar tissue and the activation of specific cells called myofibroblasts. It can affect any joint, and it's also known as frozen shoulder, stiff elbow, and a variety of other names. So we know that early modification of treatments is crucial for giving patients the best chance of recovery, and in this discussion we'll explore modified surgical treatments. And if you're interested, you can see our physiotherapy panel discussion about modified physiotherapy treatments. So, Dr. Barford, can you kick us off, please, with how did arthrofibrosis catch your interest? And can you tell us how you recognise that modified treatments for arthrofibrosis were necessary?
Thank you, Kayley, for inviting me and giving me this possibility. I'm an orthopedic surgeon and professor in sports traumatology, and what really caught me about arthrofibrosis is the double dilemma of the little I know about it and the lot there is to investigate and find out, and the problem that the patient actually are left with. So having a true arthrofibrosis patient, it's a long and very disabling condition for the patient, and we are left without very good treatment options for them. And that's kind of what caught my interest in it, that I'd like to know more. I'd like to understand the disease better, and I'd like to maybe help provide better treatment and dig deeper into to what's left underneath the condition.
Thank you. Dr. Rosenberger, would you like to introduce yourself and explain how you got interested in arthrofibrosis?
Yeah, thanks, Kelly. First of all, thanks, Kelly, for invitation to this meeting. So my name is Ralf Rosenberger. I'm professor for orthopedic surgery in Innsbruck, Austria. And I'm specialized in joint arthroplasty and revision knee surgery and arthrofibrosis. And actually, I told you, Kayley, so we see around 15 to 20 patients per week right now suffering from arthrofibrosis. So it's really a hot topic in our area in Middle Europe. And arthrofibrosis catch my interest back in 2010 when I started with revision knee surgery. And at that time, I saw 2 patients per year, and I didn't know what I should do. Now it's 15 to 20 per week. And at that time, I recognized that arthrofibrosis is somewhat like the dark side of the moon in the medical landscape. So I still want to learn about it and to know more about this topic. So thank you for the invitation.
Terrific. Thank you. And Dr. Dragoo, could you please introduce yourself and explain about your interest in arthrofibrosis?
Well, yeah, certainly. So my name is Jason Dragoo from the Steadman Hawkins Clinic in the University of Colorado in Denver, and professor of orthopedic surgery. And my subspecialty is in sports medicine and the minimally invasive ways of treating patients, namely sports injuries. And And arthrofibrosis came across my radar very early in my career when I was first studying under Richard Stedman. And he was one of the first arthroscopic doctors or sports doctors that realized that the environment of the joint was really important and that arthrofibrosis in certain cases leads to massive disability, right? And patients that can't even move their knee at all. And in certain other cases, arthrofibrosis can be very small, regional, yet still affects the patients very profoundly with their performance and especially with return to sport, etc. So at that time, him and I started studying this together and started creating less invasive techniques to attempt to get these patients to feel better and to get their motion to improve. And that has just carried on through the years to our practice. And I think this is wonderful. And again, thank you for putting this together. And I also love that we're coming at this issue slightly differently with trauma, with arthroplasty, with sports, and our ways that we have seen our patients and our different subspecialties. And I think what we'll see too is maybe we're approaching this in a slightly different way. But this is a wonderful group to come together to really talk about this. And we hope as a community we can really turn the dial and improve the treatment for our patients going forward.
Thank you very much. So my first question is around the use of mechanical shavers and avoiding the use of mechanical shavers in preference for cauterizing tools. The IAA advisors have told us that they prefer to use cauterizing tools for arthrofibrosis surgery. So Dr. Dragoo, do you agree with this approach? And if so, why?
Yeah, well, wholeheartedly. And I think the summary in my experience has been that the more invasive, the more that we alter the joint or make changes, the more of the chance that there could be some bleeding. And if there's bleeding from the surgical perspective, that can set the stage for the scar process to begin again. And these patients are, quote, revved up, or their repair system. Some patients don't heal much or at all. Some patients heal a lot, and these patients tend to be the ones of super healers. It's a good thing, yet it's a little too much, right? And so we need to manage the body's response to injury and to surgery. And so with that, as we have kind of experimented and tried to hone down technique, we first observed that patients that had arthrofibrosis surgery from a sports medicine, from a minimally invasive perspective, where the technique was to shave away scar tissue, shave away adhesions, that the efficiency of getting those patients back was not great. And we started to think, well, why is this? And we saw that these patients had some swelling, we believe to be bleeding afterwards, needed aspirations to take the fluid back out of the knee. And we kept seeing that these patients are spinning in a circle. About, maybe more than 15 years ago, there was radiofrequency ablation devices that were first used in arthroscopic surgery, maybe inappropriately. We were shrinking tissues and trying to create stability of ligaments with them. And it was labeled the tool of the devil, believe it or not, from within our profession. And then we started to say, well, wait a minute, maybe there are certain types of procedures where this radiofrequency ablation devices can be of benefit. Because what we can do is we could release tissue and or to make cuts in tissue to relieve tension, but at the same time these devices cauterize and prevent bleeding. And so maybe that is the best of both worlds. And then as we've gone through, refining our technique, we have seen better and better results when shavers are not used, and we keep the overall principle that if we're going to do releases, we do so with these ablation devices, make sure that we cauterize everything, and we have a tenet that is we are attempting to do bloodless surgery. Now, in reality, that's not true, and we're doing our best with that. But it's the approach. It's the mental focus and the approach that anything that we see is bleeding, that we do cauterize it. And the radiofrequency ablation devices have been a really good asset to improve our technique and releases, and certainly our results.
That's fascinating. Thank you. My next question is about the standard routine use of tourniquets.
Can I just have a follow-up question for
Sorry,
Jason?
sure. Yeah.
Well, thank you for that historical overview. I'm wondering, if you have an arthrofibrosis knee with a lot of scar tissue, would you then recommend to cauterize all the scar tissue, or do you mainly make a cut to release the joint and leave the rest of the scar tissue to be broken down by the joint itself?
Yeah, what a great question. And I mean, I would love to hear all of your guys' thoughts on that, because all of us wrestle with that, that wonderful question, which is tough. I think as time has gone by, I have learned that surface area, right, of our surgical procedure is really important. So it would be theoretically advantageous to use these devices if they could truly cauterize, and if they could truly eliminate our bleeding. Then if we could dissect away all of the scar tissue in the planes that we can see, then theoretically that would be more advantageous. And I think in reality that hasn't been particularly true. And what we have noted in our results is that more, as you have suggested, systematic releases at areas to allow motion that the joint, and let's just take this back to the knee maybe, where the joint needs to have motion. It's natural for the joint. And if you don't, it will incarcerate the movement of the patella. So defined releases at certain areas has proven to be better results than just massively dissecting the tissue out of the knees for the sake of discussion. That said, there are certain knees in certain areas that are the scar tissue is very thick, right? So you can think of it as that you have a segment, and the rest of the scar tissue is, let's just say, reasonable, but in a certain area, it is really thick. And all of us could probably say, yeah, we've had patients like this with regional arthrofibrosis that's really thick. In these particular areas, just doing a release at the top, doing a release at the bottom, and quite possibly even the center part may not get enough results because of the mass effect of the scar tissue. They may not be able to get the range of motion back. So then this is the difficult question for me, is in those regional areas of actually taking down and creating more surface area of our cuts, the thicker area only, and then getting the overall joint to be more compliant because of the judgment that this area, just with systematic cuts, can't get that way. It can't return. Or we could still do the systematic cuts, rehab, as you suggested, Dr. Barford, and then go back in a second time to thin and to make progress with it. The second and the third returns to operating room have not been as fruitful, and we've tried to have a goal that we get our motion, get our releases at the first surgery, and try to not do number 2 and number 3 going forward. For the same reason, these joints are revved up, we need to leave them alone and for them to remodel over time. So for the most part, it's a combination of mostly systematic releases for me, minimal dissection, big dissection of the scar tissue planes with some exceptions I'm talking about. And those exceptions are actually pretty rare. And most of the time for me, from arthroscopy, from doing this from the scope perspective, it is more releases than the big dissections. But I would love to hear from you. How do you approach this? Because you don't necessarily use arthroscope maybe as much, and maybe from a more open perspective with trauma, I don't know. But How do you see it? Is that a similar technique that you use, or are you doing things differently?
I'll give my view shortly, and then I think Ralf can give his view. I completely agree with you. I have gone from trying to dissect away the scar tissue to being as minimally to remove as little as possible when still preserving the full knee motion. So so making as small incisions as possible, I would say.
So it's the same with me, Kristoffer. So release of the tissue is much more important for me than removal of all the tissue. So it's not important for me to have a naked knee. So burn down everything to release it so that we have good a good mobility in the knee in arthroscopic surgery. In open surgery is a little bit different.
May I ask with you guys, do you also have a goal of a single surgery and trying to do your releases with trauma and with arthroplasty to have a goal of just one time that you're going to intervene, or is it routine for you guys to have a plan of multiple trips to the OR for your various patients that have arthrofibrosis?
We have a clear goal to only go once, and of course it's not possible always. Sometimes you have to go in 2 or 3 times, but we try not to do that, and sometimes we accept some motion deficits not to avoid a second and a third time.
Mm-hmm. So for us, it's most of the cases it's a single step surgery. But if it doesn't work in arthroplasty, so if we have a patient after arthroplasty with arthrofibrosis and it's a somewhat good implant position, and we want to give the implant a chance, we do it arthroscopically, and if we see it's completely wrong position of the implant, then we open up it and remove and exchange it, replace it, the new one.
Yeah, very, very similar for me. And I always tell the patients, there is this chance that we would have to do a second release, a third release, etc., to get to restore your motion or to decrease your symptoms or to eliminate them. But it is true. It's, I think, consistent notes across the board that the actual number of patients that we have to do a second surgery on is very small, in modern days. And I think we're all using the same approach for different patients as a whole, but using the same approach. And it sounds like we're getting there, as far as our technique and minimizing the return trips to the operating room.
So do you think there are patients that it would be unwise to go back to because their first surgery went so poorly in terms of the knee's reaction to it?
I mean, I'll give you my opinion, and this is a great question, right? And see how our experience matches. But for me, and again, coning this down to knees, less so for shoulders, but overall, knees, when they are hot, warm to the touch, revved up, swollen, irritable, tend overall to do poorly with knee surgery in general. So that goes in the case, Kayley, of your example. If someone had a surgery, didn't go perfectly, and so then they were left with a knee and they were miserable. And one of the first things that I think I learned and that we tried to do is to quiet these knees down before our approach of surgery. Because when it's hot, when it's in the middle of a really inflamed cycle, then it is very tough or tougher to get results, at least for me. And so the first part, and this just happened like a week ago, somebody came in and said, I need surgery, I need it now, I'm miserable. And I said, no, we are much better off waiting, maybe using medications and other physical therapy, giving some time between that index surgery and the next one that you will need, and then able to have a more quiescent knee and able to make more gains than I think we would have, or by practice we would have. Results have not been good and operating on those really inflamed knees. But it doesn't mean that surgery is not good for them. It means the timing of the surgery is not good for them. And then that carries forward to patients that may need more than one surgery. Do we do a surgery and say, oh, geez, we're not completely there. Let's do another one in 6 weeks. No way. That the timeline in between surgeries, at least for me, has to be much longer for the knees to attempt to turn the corner, to become less revved up, less inflamed. And so then that return to surgery between surgeries is at the very minimum time of 6 months for me, and sometimes it's better for those really irritable knees to be greater than or equal to a year to really get good results. So as we're all saying, this is a long-term sort of treatment, but the results have been better with that. How about you guys?
So it's very interesting to hear that you have this 6-month limit, saying, if you've done your arthrofibrosis surgery and you see them climb back after 2 to 3 weeks, getting more and more restricted. I've gone in after 2-3 weeks at some patients there, and it hasn't been a success. You might have a very good point there. I don't know what you say, Ralf.
If we decide for surgery, it's not so much the question for me when it's the right time. So the time is when it's not moving, so I do the surgery, especially knee arthroplasty. If we can see, if I did my analyzation of the implant position, I think and I can see that's completely wrong, and the patient cannot move. A, I do the arthroscopy, or B, replaced it, put it out and do a revision knee surgery. And in most cases, when I do this, then it's done with it. So I don't need another surgery, maybe in 2 or 3 weeks or months. So once I did it, then in the most cases it worked. Like that. But I think there's not 100%. It's not black or white, in my opinion. So it's the feeling of the surgeon, and is very important, I think. Yeah.
But don't you recognize this situation where you have a patient with maybe flexion from 30 till 80, 90, and you go in and you release them so they can move from 0 till 120, 130, put them in a CPM machine, and then slowly they crawl back up. And how far do you go then before you consider a new brisement fossé or something? Will you wait still for half a year, Jason, if they're back to what they came from after 2 to 3 weeks, or would you go on them again?
For me, the goal is for that not to occur. So then how can we do that? How can we alter their response to the surgery that's going backwards, right? And for me, yes, physical therapy and not as much CPM, but that is an active time of treatment, yet it's not an active time of surgical treatment for me. And I know Kayley may have some questions, but maybe this is a great time for, what is the role of medications in this whole thing? Because I think in summary, we could say from the surgery perspective, hey, we've done our part, because the proof is you have your full motion or our goals of motion right after surgery, right? Kind of proof of the principle that from the surgery perspective, things have been done okay, right? And so then the question is, okay, well, what about the management of the body between that time and going forward? Can we keep it? And if we can't, it might not be the surgical issue that led to the restoration of stiffness, right? The return of stiffness, but it may be the body's response to surgery and the body's set point and trying to get back to the way that was before. So For us, we really active management, and this is the more the medical side of things, of really trying to use medications to suppress the body's response for the rescarring. It starts with number one, during the time of surgery, our workhorse anti-inflammatory is Celebrex, celecoxib, and because I know around the world, one of the only COX-2 inhibitors that we have is really fundamental to us for the reasoning that it's the only one of the NSAIDs that doesn't alter platelet function. And if we use our standard NSAIDs, then that alters platelet function and we can have the return of bleeding because sometimes we have to give big doses. And so then that could be counterproductive. So using a non-platelet altering medication is kind of fundamentally number one. Number two, there may be some interplay of a systemic inflammatory response in these patients. And we don't really know how to categorize it. No, it's not lupus, and no, it's not rheumatoid arthritis, and not necessarily even multi-joint involvement. But there's something that's driving this inflammatory scarring response locally. So we do use at times more of the immunosuppressive, bigger gun type medications. Again, we love to hear the shared stories of this, but for us, corticosteroids is a big one. And I know what we're all thinking is like, holy cow, be careful, because these patients are also more susceptible to infection. And so we need to manage that one pretty carefully, and with doses and pulses of corticosteroids to manage the inflammatory response, which tends to also have in the knees and our joints anti-collagen responses. At a time point of plus minus 6 weeks, if we see that patient kind of reverting, showing this, also giving an injection into the joint to the corticosteroids. I know a lot of practices, including mine, have gone away from corticosteroids, yet this may be one of the good parts of corticosteroid, because not only does it have anti-inflammatory properties, but it also has anti-collagen properties, or decreases collagen production. One of the side effects that are oftentimes bad, but in this case could be good, and we can leverage that. Losartan has been shown in animal studies, and that's a large thing from Colorado, looking at animal studies. So for tough patients, we do put them on losartan ahead of time or at the time of surgery. And for me, we're trying multiple things. So it has been unclear, let's just put it that way, unclear of how much losartan helps. It certainly helps in the animal model, but it has been I can't tell, because we're doing a lot of things together, that I can't tell that as we've added losartan, it's really changed things. But yet it's one, because there's some basic science to suggest that that's beneficial. And then the other one to consider for us is doxycycline. And that's one where occasionally we have tough patients, all of us, and they are really susceptible to infection just because of the nature of their injury and their condition. And sometimes we have to give we always have to give antibiotics at the time of our surgery. Doxycycline is not necessarily a wonderful antibiotic for what we need from a surgical perspective, but it's a good adjunct. And if we ever needed a patient that needed a little extra prophylaxis of treatment, we placed them on doxycycline for a small period of time afterwards. That, again, those are the tough patients, and we're doing so many things to alter the joint and the process of healing. I don't know how well or not, it's just kind of not discernible how well that tool is, and adding that to the plate. And then finally, there are some that and you guys gave great examples of this, that it's like, oh my gosh, this is not going great. We need to do something different because this is not going in the right direction. Do we do surgery, yes or no? And again, for me, the answer is no from the surgery perspective, because it's not the right timing. But yes, I give them then to rheumatology, and we even have higher types of anti-inflammatory, immunosuppressive to extent medications that are used for inflammatory arthritis to again fight the body's response. So you see, for me, this is a medical active management, and for me, not surgery, because I, in doing this for a long time, have been unable to turn that course by intervening quickly within 6 weeks, 10 weeks, and something like that, because their body is too revved up to do it, and surgery just hasn't been the answer to me. But I mean, of course, we would all love to hear what do you guys do? Like if you make the judgment, Ralf, that you said, you know, my judgment is not to do it, but I'm worried about this patient. What would you use from alternate other surgical tools besides physical therapy and CPM to treat that patient? Do you have a similar type of strategy?
So for me, is treatment of the arthrofibrosis is teamwork. So it's extremely important. So the management, pain management after surgery, extremely important that you have a good experience in arthrofibrosis, experienced anesthesiologist. So, and he's doing the pain management as long as the patient is on the ward. And this much matter, the patient should have no pain. This is extremely important. And then when the patient is at home, so he gets his oral pain medication, of course, and maybe later on the NSAIDs. And then for me, it's very important for me to have a strong collaboration and a concept, including the physiotherapist. So when he's leaving me, he's going to the physiotherapist, but we all talk together and hear us once a week or twice a week, or the patients stay in the area in Innsbruck when they are not from Innsbruck, because this is extremely important. I don't want to do surgery and then say bye-bye, ciao, that's it, and now show how it works. That doesn't work. So it's always a combination for me, and then it can work.
Kristoffer, what's been the medical side versus, you know, that you decide that it's no, you know, on the surgery, but you're really worried the patient's kind of reverting back. What has been your tactics?
Like you say, we've had a package where we put patients 2 weeks in hospital, hospitalize them for 2 weeks. And if it's a really difficult case, I think the pain medication is extremely important. And some of them have had a spinal for 2 weeks in order to be able to work with the joint. But then, of course, you also take away the sensation of pain, and you might overwork the joint. And it's an extremely expensive solution to do it like that. And also the anesthesiologists, they don't like making spinal catheters, and but it's only been a few that we've done like that. I think the collaboration with the physiotherapist, it's absolutely key. And I'm sorry, Kayley, time is totally running now, but actually I have a short follow-up question for Ralf and Jason, if that's okay.
Sure.
Because I'm wondering, do you have like a standard package saying that these patients, they all get, if they do not move properly at day something, they will have this, or are you like feeling your way through? This patient gets corticosteroids, this patient gets losartan, and this do we have some kind of or can we agree on some kind of a guideline saying that after this time, if a patient is regressing, they should maybe have?
I basically skipped the steroids nearly completely, 59%. I completely skipped it. I don't use it anymore, only in just a few cases. And also the beta blockers, I skipped it. I have never seen any advantage with this in my experience. So I don't know if it's wrong or right, but I have never seen any advantage with this. So it's, for me, I'm not sure yet. I don't know what the science says. What's good in pain treatment in arthrofibrosis, there's still not so much literature out there. Maybe the NSAIDs, aspirin, that works, but Everything else is, I think, a little bit eminence-based for me.
Yeah.
Jason?
Well, I agree that the evidence, that to really guide us is not there. But I think if I was to vote for something as far as the standard treatment of the patients, I would vote that the algorithm should be an individualized algorithm rather than one that's a boilerplate one, because just as I think we have all experienced, one thing that works for one patient doesn't necessarily work for all. I totally agree that my use of corticosteroids is very minimal, but as for those very indicated, tough, off the grid, different patients, and then occasionally we have to use these array of things, but they're all different, that aims to be very responsive to the patient's condition and how they're reacting medically, rather than my next step is this and then it's this, because that has not worked out to have a boilerplate kind of plan. And I think if anything, and I'll speak for the sports medicine practitioners, that if anything we've got wrong in our field, it is trying to approach a patient with a certain condition in the same way all the time, to think that that's going to be our best answer, and to try to standardize things. And regardless of what it is, it just tends to not work. And this individualized approach to the patient, regardless if it's arthrofibrosis or some other issue, and could be rare issue, that we have done better in our side of the fence, in our subspecialty of really individualizing the care. And that would be the vote for me, is to continue to really pay attention, know what you can do, right? Have all these things out there that we know that we have in our tool chest. And then it is up to the surgeon and their experience of what of these tools is going to be best for that individual patient. That would be my vote.
I totally agree with you, Jason. Totally agree. Yeah.
I agree as well that it's where we are, but it concerns me a little bit, because then it is truly eminence-based, and we don't know whether it's working or not. So it would be preferable to move it to something that's evidence-based and not that eminence-based.
We definitely may need a lot more research. There's no doubt about that.
But it's also then, are we prepared, like us three, right? Are we prepared to do randomized trials and to try algorithms that are part of our science, right? So we can understand what really works and really not. And for me, I would have trouble with that, just because, we have an arm, they're randomized into an arm. For them, it's like, oh my gosh, okay, we're going to give them this treatment. I don't know if that kind of evidence-based approach is really tough, is what I'm saying, for these patients. And again, for the spectrum that we see, such as very regional arthrofibrosis, and their loss of motion is 2 degrees of extension. And you guys, both of you, are probably saying, oh my gosh, what are you talking about? It's not even on my radar screen. But for us and our athletes, if they lose 2 degrees of extension, that's the end of their career. That they cannot perform, they cannot play soccer, they could not kick the ball the same. And so then it becomes really important. But then maybe more of your experience has been these folks that the knee doesn't move at all, or if they do, they have a total arc of motion of 40 degrees. That's totally different. And so as we study this together, it's really hard, that evidence, Kristoffer, that you were talking about, to make these trials and to agree upon that association we were all in of arthrofibrosis. How would we study these patients? It's actually, to think about it, it's actually really tough to do. But I agree with you and everyone, and Kayley, that we just don't have enough good data, to be able to talk about this as a group, to come up with an overall solution. And so therefore we end up having very anecdotal conversations, don't we, about our career and what we've had and our experience. And although that's better than nothing, it's not quite that high level of evidence that we would all love.
I'd just like to go back to that very interesting comment you made, Dr. Dragoo, about waiting and not operating on a very inflamed knee. And I'd say from my perspective, from the research about how inflammation contributes to fibrosis, that sounds like a very worthwhile approach to me, because there are a lot of very powerful feedback effects between the immune cells, inflammation, and the myofibroblasts that create the scar tissue, which react to that inflammation by creating more inflammation. So if we add to that inflammation by more surgery when there's already very activated myofibroblasts, we're only feeding that whole negative feedback loop and potentially making it worse. So, yes.
Yeah. But it's interesting from our perspective, right, with that. And I think we've all, and this is also for our patients, right? Today's discussion is also for our patients. And maybe we've all had the experience, I certainly have, of patients being very upset with me, right? And saying, sometimes they come in and they've already had, I'm going to make it up, 7 surgeries. And they say, okay, well, this one's the right, and they feel better day 1. It's like, oh, I'm finally there. And then 4 weeks into it, it's like, here we go again. I need another surgery. And I'm saying, nope. What we're going to do is we're going to change it. Here's what we're going to do. I'm not ignoring you, but we all talked about the coordinated teams and the physical therapy and then the medical approaches. But what I wanted to say is, Kayley, sometimes it's a very difficult discussion, and patients are very upset and saying, you are withholding care from me, and it's the best thing to do a surgery again. I say, no, I know it's the best thing not to do surgery again. And so this is something that, if we do recognize that there are better times in surgery and we really educate our patients, maybe even saying that up front to them, is that there may be this time that we go in a new direction, can help save those really difficult conversations, because we're acting on behalf of that patient, but the patient may not understand that, and they feel that sometimes that their care is being withheld. They feel neglected because they're spinning, and they've gone in the spinning cycle for so many years, and we're trying to get out of it. And so then that's just something I think that from all of us as we talk about surgery and yes or no, that we come together to really educate our patients that it's not always at the time that the patient thinks that surgery is necessary. It's not always been our experience that is true.
Yes, very difficult conversations, and maybe, as you say, it's a good idea before the surgery to counsel people that, look, if this doesn't go the way that we hope it does, if your knee reacts in a very negative way, then you need to be prepared to postpone that next surgery until it's settled down, perhaps. So they're prepared in advance before that situation arises.
Yeah, quite possibly. Just one of, again, the individualized care, and as Ro was saying, the experience of the surgeon who is doing this, and then there'll be a gut feeling, there'll be an experience pattern of hundreds or thousands of patients, and it's like, no, it is not the right time, and then for the patients to respect that this is something that we have learned, but very individualized, and we couldn't come up with how they're going to do after surgery beforehand. We just have to have the conversation that it might be different than we all expect, and we're going to be prepared for it. And that, I think, is a really good conversation to have.
Thank you. That's very helpful discussion, I think.